All right. So sorry. So with chorion amnionitis, we are looking at the risk factors. And the risk factors, whenever you are looking at risk factor and there's time on it, please take good care of that. So the first thing that you should know is what? Bacteria. Okay. So ascending bacteria. And the second thing is rupture of the membrane, and that is prolonged more than 18 hours. And when we are having multiple vaginal examination, every now and then you are checking, you are doing V. Okay. That one will predispose the mother to infection. All right. And when you are doing internal fetal monitoring, not the external. You know, the external, you just place the monitor on the fundus or on the abdomen. But with the internal, we place the electrodes at where? Where do you place the electrodes? Hello, class.
At the fundus, right?
Internal
Inside,
monitoring. Where?
inside, through the vagina,
To where?
into the uterus.
Okay, thank you. But any other? Where do we place the monitor, the electrodes? I just told you last week, or is it last week or 2 weeks ago? Yes. Fetal head. You're looking at the head. I told you the conditions if you are
the fetal scalp.
Yeah, the scalp. Okay. And you should know if you're able to do this, there should be a rupture first. There should be dilation of more than what? 2 cm. Okay. So internal monitoring, you are placing the electrodes on the fetal scalp, and that will place the mother to get this condition, okay, chorion amnionitis. I hope that's clear. And prolonged labor, the same thing, the same scenario. When there will be ascending what? Infection. Okay. So it's like having prolonged rupture of membrane. Okay. That will predispose the mother to getting bacterial infection. All right. And when you do amniocentesis, I hope you remember amniocentesis. Okay. The mother may develop postpartum endometritis. Okay. And neonatal sepsis. All right. Because this one, we are using a needle. Okay. So once you are entering the inside of the mother with a needle, okay, that one will place the mother to that. Okay. So know that when we have amniocentesis, we do amniocentesis, it can predispose the mother to have a postpartum endometritis. Postpartum. So once the mother has delivered, the mother will start having infection. You have to know. Okay. All right. And neonatal sepsis. I place okay. But with endometritis, I told you that with this, when you are having this thing, infection, because normally we may have an increase in temperature after delivery, isn't it? Mostly for the first 24 hours. Okay. But when we have more than 38 degrees, that we need further investigation. When you're having more than 38 degrees, okay, that could be as a result of what? Infection. So in that case, you have to monitor the woman, okay? But postpartum fever for the first 24 hours of up to 38 degrees is normal. It's considered normal. Okay, so we just have to continue to monitor the woman. Are you okay? All right. So when we have temperature of 38 and above, so that one, the mother is at risk. Or we have temperature of 38 point something. It means that the mother is having infection. Okay. And once the mother is having infection, possibly there's going to be an increase in the heart rate. All right, the heart rate of the mother. Okay, so maternal tachycardia of more than 100 beats per minute. Uterine tenderness. Uterine tenderness is going to affect the uterus. Okay, it will be very painful. Once you touch the uterus, that'll be very painful. Okay, so if you are touching the mother is pregnant, you're doing your normal assessment, you touch the mother's abdomen or uterus, the mother feels pains, please do further assessment. Okay. And because there's an infection, obviously there's the fluid that is coming, be foul smelling. Okay. And leukocytosis. Okay. You're looking at what? White blood cells. Okay. An increase in white blood cells. Okay. There's going to be chills, fetal tachycardia. So that's the early sign. Because once we're having chorion amnionitis, that's where the child or the fetus is lying. So the fetus is going to experience the signs and symptoms first. Okay, so you see that the heart rate will be racing. Okay, and uterine tenderness. So that is it. All right. So what are you going to do if we are having endometritis? If you have chorion amnionitis, you have to notify the provider because the child is at risk of getting infection. And once the child gets infection, the child can get what? Sepsis from it. Okay. That's what most of the times that after delivery, you see that the fetus to be having very high temperature and be having neonatal sepsis, all because of what? The infection that they got it from the mother. Okay. So you have to notify your provider and give antibiotics. Okay. But this one must be done after what? You've obtained culture. With antibiotics, because we have to target the kind of bacteria that is causing the problem. So if once you want to start antibiotics, find out the kind of bacteria that is doing that before we know the kind of antibiotics that we are going to give. Okay. But we don't wait. That's why we start with broad spectrum, because we don't wait for the result to come. So once you give broad spectrum, it's going to have effects on all the bacteria that we'll be having, okay, before the actual result comes, okay. And we have to continuously monitor the fetus, okay, the fetus. We have to monitor the fetus, all right, and the vital signs as well, okay. You monitor if there's uterine tenderness, contraction, the frequency, the duration. You have to be monitoring, okay. Fetal activity, the fetal moving, the fetal heart rate increasing, the respiratory rate is increasing, all the thing that's like activities of the fetus you have to monitor, okay. And once the results comes, then you target the bacteria with the right antibiotics, okay. And here it's not, when you have chorion amnionitis, it's not automatic that you have to do CS. No. Okay. CS is not the best option if you have chorion amnionitis. Okay. Unless we are having fetal distress. Okay. If there's severe fetal distress, of course, you have to do that. Or if the infection is worsening or we are not seeing improvement in the labor, okay, then we opt for what? CS, okay. And after delivery, because we want to prevent sepsis, we have to obtain neonatal cultures. Okay, so it's not only the mother that you are going to obtain culture, you have to do it to the child as well. Okay, so as I said, once we have coronary amnionitis, it is not an automatic CS indication. Okay, if the woman is stable, there's no fetal compromise, you can safely deliver the mother per vagina. Okay, so that's what you should know. It's not an automatic thing that you have to go and do CS. So if you get coronary amnionitis and there's CS to be one of the indicated, okay, please, it's not indicated. Okay, unless there's fetal compromise. So read the question, read your case notes well. Is the baby having distress? Okay, if not, then we can safely deliver the mother. All right. So what are some of the common complications that we have? Neonatal sepsis, very common. Pneumonia, because the child is swimming in a fluid. And if there's an infection, okay, this is the same fluid that is going through the lungs. Okay, the same fluid. So it's possibility of getting infection. Depending on the kind of bacteria that we are having, the child can also get what? Meningitis. Okay. Cerebral palsy is also common, and that's a long-term risk. All right. And hemorrhage. Why? Why hemorrhage and coronary amnionitis? Yes, please.
I think because the uterus is refusing to contract.
Okay.
Mhm.
All right. Thank you. Because the uterus will feel lazy to contract. Okay. After delivery, that one will cause the mother to get postpartum hemorrhage. Okay. Endometritis. That's one of the commonest cause of endometritis, coronary amnionitis. Okay, because there's infection of the colon. So once the mother delivers, if you don't initiate your antibiotics promptly, the mother will get an infection afterwards. Okay, so afterwards the mother will be feeling tenderness, low back pain, and those stuff after what delivery. So you should be mindful of infection that the mother will be having. Okay, and apart from that, sepsis is also common because this one can just go into the blood and have systemic infection. Okay. So please take note of this. If a baby is born after the mother, you see, let's assume the man that got fever before delivery. Okay. And there was also fetal tachycardia. And once the mother delivers, please, you have to assess the mother. Your first thing or your priority to do, the most appropriate thing is what? To assess the newborn for signs of infection, because the mother was having what? Infection. Okay, and the child was showing signs of infection in utero. So once the mother delivers, you have to assess the newborn for signs of infection. So that is what you should know. Okay. Let's do some questions. A nurse is caring for a client who is scheduled for amniocentesis. Which of the following should the nurse include in the client teaching? Amniocentesis. What are you to include? You will need to have full bladder for the procedure. You will need to lie on your back for the procedure. You will need to have someone drive you home after the procedure. You will need to avoid eating or drinking for 8 hours prior to the procedure. What do you think? Please answer. Yes. I read it.
You will need to have a full bladder for the procedure.
You need to have full bladder for the procedure. Okay.
I would go for C. You would need to have someone drive you home after the
I also
procedure.
go for C.
You also go for C. Driving home after the procedure. All right. Any other? Yes.
I think I'll go for B.
You go for B. Okay. You need to lie down on your back for the procedure. Okay. All right.
When the patient lie on their back, when they experience vena cava syndrome.
Mm-hmm. So you know that. Okay. And even that, why do you have to need a full bladder? Why full bladder in amniocentesis?
Anyway, I read some time ago that the full bladder is needed to support the womb,
So it helps.
depending on the trimester that the pregnancy is.
When
So
do we do amniocentesis?
First trimester. 15
When?
20 weeks. 15 to 20 weeks.
Is it first trimester or second trimester? First or second? 15 to 20 weeks is what? Second weeks. Okay.
second trimester.
Trimester, yeah. Second trimester. Okay, that's when we do amniocentesis. Okay. 15 to 20 weeks of gestation. Right. But then, because you are doing amniocentesis, you're taking cells. You're taking cells, the cell fluid, and that one would include the cells of the fetus. Okay. So that's when it's best to do amniocentesis. So if you are doing amniocentesis and having full bladder, you say it's going to support. But okay, that's anyway. But are you thinking of possibility of rupturing?
Yeah, that was what
Because
I
of
thought.
yes, because of you are introducing what? A needle. Okay, you are introducing a needle. So you have to think of possibility of rupturing. It's not like we are having you are doing a scan. Okay, unlike scan where you have to have a full bladder. Okay, full bladder. With amniocentesis, because of the needle, you have to be very careful with the bladder. Okay. And this one, why do we have to drive, someone has to drive the mother home? Why?
Maybe
For
as a
sperm.
result of the
Mm-hmm. Yes, please. Okay.
Hello.
So, yes, please.
Okay, I'm taking the answer C. You'll need to have someone drive home after the procedure because there are possibilities of bleeding and some cramps or leakage of the fluid.
Okay.
Yes.
All right. So obviously,
Thank you.
the answer is what? C. All right. So we because we are going to remove fluid with the help of what? Needle. Okay. So we don't want to, and because of cramping and bleeding, and leaking. There can be leaking as well of fluid. All right. So because of that, the mother needs rest to avoid strenuous activity, to prevent bleeding, prevent leakage. Okay. So that is the best option. All
Okay,
right.
so well, is this done under ultrasound scan or something?
Sure.
So is the full bladder counting here? Because
Is the full bladder what?
is it counting because we are doing an ultrasound? Usually they do that with full bladder to push the uterus in position so that the it will be clearly seen or something. So is it still needed to have a full bladder?
For
Is it
amniocentesis.
counting? Yes.
For amniocentesis, we don't need full bladder.
Okay, so there's no scan then.
We do use scan because we are introducing a needle. So we want to prevent an injury to the fetus.
Okay.
Okay, we want to prevent an injury to the fetus. So because when you introduce a needle and with the help of a scan, you know, because you are taking fluid. So you know where the pouch to take your fluid from. Okay, and as much as possible to prevent injury to the mother.
Okay.
Right? Okay.
Boss Frank,
Yes, please.
I have a question.
All right.
So, comparing the two, we know that when we are taking abdominopelvic USG, we need the bladder to be full. And the reason they give is that to give I don't want to give an accurate imaging or something like that, to enhance the imaging of the endometrium and then whatever that is growing inside there. So with how come that in the amniocentesis we do not need full bladder to enhance whatever imaging that is going on?
Okay. Any answer?
Boy.
Yes, please.
And please, again, too, I also read that before the 20 weeks, the bladder needs to be full, but after 20 weeks, yeah, is then that one you can empty the bladder, but to the early stages, you have to keep a full bladder. So I'm a bit.
No, I don't get your point. Please come again.
I'm saying that I also read that before the 20 weeks, you have to keep a full bladder just to push the uterus. Yes. And after 20 weeks, you have to empty the bladder. You can do it on empty bladder. But
With amniocentesis?
Yes, boss Frank. I also read that. I saw that.
Yeah, I also saw it.
If the pregnancy is less than 20 weeks.
Yes.
Because you're saying this procedure is done in between 15 and 20 weeks.
Sure.
And so the patient will need a full bladder for this. So I chose option A.
One thing is that we let me go back to the question. We are caring for a client who is scheduled for amniocentesis. And the question is asking, which of the following should the nurse include in the teaching? All right. So with amniocentesis, what are we doing? Our focus is not having full bladder will push will help you to visualize the uterus and sometimes to push the uterus into its correct position so that you know the uterus. But in this case, with amniocentesis, we are just introducing a needle. We are introducing a needle into the abdomen. All right. So if you because this case if you are having full bladder, possibility of rupturing is high. It's not like a scan where you are not when you are using a scan, okay, with normal scan, we can just you need to have the full bladder to visualize the uterus, to place the uterus in its correct position so that you can do your assessment or your investigation that you want to do. But in this case, we are introducing a needle. Okay, and our focus is to prevent uterine rupturing, bladder rupturing, as well as to prevent injury to the fetus. Although we know that in most at times with early pregnancy, we do have full bladder. That's with most of the investigations. Okay, with when you pass the first trimester and the second trimester and the third trimester, you are doing it because the uterus is already up. Okay, the uterus is already up. So with that one, you can quickly or can easily see the uterus where the position is. All right, but with amniocentesis, because of we are introducing a needle. We are introducing a needle. We want to prevent rupturing of the bladder. That's why in this case, or with the options that we are seeing, the best thing is to have the mother, someone drive the mother home because of the leakage. Because our focus is in the needle, not displaying the uterus. We are not going to visualize the uterus. We are just taking a fluid. Okay, our focus is take fluid. That's the whole thing. We are not going to assess what is the uterus. That's not what we are going to do. We are going to take fluid with the help of a needle. As much as we do have full bladder in most of the with most of the procedures, with amniocentesis, we are introducing a needle. Please take note. We are introducing a needle into the uterus. And once we are introducing a needle, please, we want to prevent rupture. That's the first focus. So if you have full bladder, because we know that with most investigation, we need full bladder. You are wrong here because you are going to rupture the bladder. Are you okay, please?
Yeah, we are okay.
Hmm?
And sir, can I come in small?
Yes, please.
So I was also thinking that the question didn't mention like the gestation. For we know that if the pregnancy is less than 20 weeks, that's when you will need a full bladder. So
But
since
with what procedure? What procedure are you having to need the full bladder?
amniocentesis, the pregnancy is 20 weeks.
Yes, 20 weeks.
Mention like less than 20 weeks or the gestation.
But we know when to do amniocentesis.
Yes, so that's what I'm saying, that A can't be the answer because they didn't mention any gestation for you to know that, oh, this is when you need a full bladder. So A can't be the answer.
But when is this procedure done? Is it
It's
not done between 15 and 20 weeks?
Yes.
So the question thinks, or the question knows, you know, the weeks when this procedure is done. So there's no need for the question. There's no need for that to be, seen here. So we understand that.
Them saying is 15 to 20 doesn't mean it's a must for you to be done between the least gestation is 15. Even after 20 weeks, I think it can still be done. That's
Even
when
at 28 weeks gestation, it can still be done.
Yes, so that's why they are saying if it's less than 20 weeks, that's when you need the full bladder. But if it's more than 20 going, you don't need it. You don't need it.
Yes.
So please, it's not usually about needing a full bladder in the first trimester and needing an empty bladder in the second trimester. you have to consider the test that you are doing. The test that you are doing. With amniocentesis, because we are passing a needle, please.
There is a risk for bleeding.
Don't go and rupture someone's bladder. Because doing it with full bladder is not going to change anything. It's not going to change anything. The purpose of the full bladder is that you want to, because in the early sizes, the pregnancy is usually in the where? Where do we find the uterus? Where?
Lower abdomen.
So in the saying second trimester, we don't need, all because we want to push the uterus upwards to its correct position. All right. So that's the normal, that's the standard. But with amniocentesis, because we are introducing a needle, there's no need for full bladder. If we do that, we are going to rupture. So please, don't think that we need full bladder for amniocentesis. Never true. Yes, please, Mr. Jacob.
Okay, just to add a little to what you already said. When we were discussing this, I also tried to cross-check. When I cross-check, it is like it is in the early pregnancy. And when I check what is meant by early, it said between 11 and then 14. That is where, you need a full bladder, but 15 to 20 is even considered late, and you don't need full bladder. And looking at the question, considering full bladder and then the risk the mother will go through, I think the risk on the mother outweighs the full bladder that will give a view, because even without the full bladder, you can still do the amniocentesis and then without problem. But the mother has a risk when there's cramps and there's bleeding. So considering the priority, the C will carry the priority more than the A. And even with the fact that you need a full bladder at the early pregnancy, the early pregnancy here will be around somewhere below 14. So 15 and above, it's even still late, and you don't need full bladder. Thank you.
All right. Thank you so much. So please, it's just simple thing that you should understand. Amniocentesis, you don't need full bladder. As simple as ABCD. Okay, amniocentesis, you don't need full bladder. So please take note of it, and it shall be well. All right. Okay, a nurse is caring for a client scheduled for amniocentesis. Which of the following should the nurse report to the provider? The one that you should report: client has history of asthma, history of diabetes, history of bleeding disorder, history of hypertension. Which one's the correct answer?
B, sir.
What?
C.
B for boy.
C for cat.
C for cat.
C.
Okay. Bleeding
C.
disorder. Okay. Because of what? There's still needle. Needle. As simple as ABC. So a nurse is caring for a patient who is at 15 weeks gestation, RH negative, and just had amniocentesis. Which of the following interventions is the nurse's priority following the procedure? Check. So the mother just had amniocentesis done. Okay, 15 weeks, RH negative. What's your priority? Check the patient temperature, observe for uterine contractions, administer RH raw immune globulin, and monitor the fetal heart rate. What's your priority here?
C for
D.
cat. Administer.
Monitor fetal heart rate.
Monitor fetal heart rate. Okay. Monitor fetal heart rate. Any other? So we are having C, and D. Any other?
C.
C for car. All right. Any other?
Boss, Frank, I remember you said we should monitor fetal heart rate before and after. Then after the procedure when the mother is RH negative, then we can give the Rogan.
Mm-hmm.
So
and
the priority first
Mhm.
must be the heart rate, then later we come to the Rogan to administer.
I think that the RH is not emergency, it's not immediate in the sense that though the procedure can cause RH ISO immunization, but it's not urgent as monitoring the fetal heart rate. Though it's also correct, but between the two, we will have to monitor fetal heart rate first before.
Okay.
If there need be, you can administer the room.
All right. So sometimes it's important for you to read the some of the, I would say, the modifying words. The modifying words. Okay. Important for you to read that. If you know your modifying words, you easily get the answer. All right. So that's what I want to tell you. So the answer is obviously C.
Yes,
Because
ma'am.
according to the modifying words, the bladder is RH negative.
Yeah.
And is what? We did amniocentesis, RH negative. All right. We are to monitor the heart rate. But is there indication to monitor the heart rate in this scenario?
No.
So please, that's the whole trick. That's the whole trick. Is there any indication? Mr. Godwin?
So you even mentioned that when the gestation is aging 15 to 20 weeks, no, we should even give the gestation weeks, no, to prevent hemolysis or agglutination. I remember.
Okay, thank you. Mr. Godwin?
Yes, Sir Frank.
Yes, please.
The second question, I didn't get it, so I was thinking if I could.
The second question before this?
Yes, please.
This one?
Yes, please.
Yeah. Looking at the whole thing, it says you are caring for someone who is scheduled for amniocentesis. And the one that you should report, patient with asthma, what's the link between amniocentesis and asthma? You are passing a needle. The link between amniocentesis and asthma, is it going to increase the risk of diabetes or asthma?
No, please.
Is it going to, a bleeding disorder, will it have a problem? Hypertension, will it have a problem? So the correct answer is bleeding disorder.
Yes, that's what I chose. Later on, I didn't hear that, so I wanted to just confirm.
Okay. So that's
because
the answer.
Earlier on you said there's risk for bleeding. So if the person is already having a bleeding disorder, then that should be a concern.
Sure.
All right. Thank you.
You're welcome. So per the scenario, so the whole thing is that when you are reading the question, please, you shouldn't read into the question. You should read the question as it has been given. It is giving you that the mother is RH negative. So that is the modifying word that the question is trying, it's even helping you to get to the right answer. So once you've been given the modifying, take note of the modifying words, and that will help you. Okay, there's no indication to monitor or to it will be your priority to intervene. Okay.
Boss.
Yes, please.
Please, let's assume the mother is RH negative. And could it be that the baby too maybe probably maybe RH negative? Are you still to give the ROGAM?
No, negative positive. That's the only one we give.
So my problem now is that how do we know that the baby could probably be maybe positive?
Very good. That's a good question. But I want to kindly or sincerely tell you that English, we don't read into the question. Okay. We assume what if. Okay. We just have to read what the question has given us.
Okay.
Okay. So RH negative. And with all RH negative, you have to give immunoglobulin, provided the fetus is what? Is positive. And here didn't state. So whether this or that. So we are not going to assume that what if is negative, what if is positive. Our priority is to prevent sensitization. All right. So okay. That's will be our priority. Thank you.
Boss, and also the 15 weeks, I think they say we should give 28 weeks. For the 15 weeks, it cannot disturb, right? Because of the amniocentesis.
That is a routine. When you are doing routine antenatal assessment or antenatal care, or routinely we do give it on the on that date. Okay, that's 28. Okay. But if we are doing certain procedures like this, we shouldn't wait for the 28 days. On the 28 weeks.
Okay, thank you so much.
All right. So, a nurse is assessing. Yes, please.
Sorry for cutting you. So,
All
how
right.
many ml of the fluid do we need for the test?
How many ml of the fluid?
Yes.
Oh, just something small, because with amnio I hope you are talking about amniocentesis, right?
Yes, boss.
So when we take amniocentesis, okay, one thing is that what are we going to do? We are going to, we know that this test assesses the genetic, okay, if the mother is having any genetic conditions or any other thing. So this test, I hope you know spinal needle. Have you seen some before?
Yes, boss. I've seen some before.
It's similar to the spinal needle. You just take about few, just small, something from about 30, 20 ml. Not too much.
Okay, thank you.
All right. So a nurse is assessing a client who is in labor, has a large baby with cephalopelvic disproportion. Okay. The nurse should monitor. So look at the qualifying word or the modifying word. So large baby with what? Cephalopelvic disproportion. The nurse should monitor the client for signs of which of the following fetal complications: shoulder dystocia, cord prolapse, fetal distress, hydrocephalus.
Boss, the answer is already highlighted.
Don't be deceived. Anyway, yes, so you are going for A, shoulder dystocia, right?
Yes.
Yes, I was.
Okay. Okay. All right. Anyway. All right. That's a cheap question, though. Why is it that the okay, anyway. 50, 30 minutes. 300 milligram. Yes, yes. So sorry. A nurse is teaching a group of pregnant women about the risk factors of prolonged and obstructed labor. Risk factors for prolonged and obstructed labor, Which of the following statement by one of the women indicate a need for further teaching? So the qualifying word or the modifier is prolonged and obstructed labor. The one that indicates further teaching. I should avoid gaining too much weight during pregnancy so that he's at risk. I should take vitamin D supplement to prevent rickets. I should deliver my baby before I turn 35 years old. I should drink plenty of fluid to prevent polyhydramnios. Yes. Which one of will need more further teaching? Looking at the risk factors, okay, for prolonged, so we are looking at the one that is not a risk factor for what? Prolonged and obstructed labor. All the answers are risk factors for prolonged and obstructed labor. Which one is not a risk factor? That will not cause prolonged labor. That will not cause obstructed labor. Which one? So when the mother tells you, I should avoid gaining weight, it's not going to help with easy delivery. It's a risk factor. I should take vitamin D supplement to prevent rickets. I will know rickets. I should deliver my baby before I turn 30. Prolonged labor. Is age a factor? I should drink plenty of fluid to prevent polyhydramnios. Which one? Quickly. Let's move. Yes, please.
I think it's D.
I should take vitamin D rickets to prevent rickets. So when the mother says that, he needs further teaching because it's not a risk factor for prolonged and obstructed labor. Is that it? All right. Thank you. Any other?
No, I said
So
I'll be
the
going for
answer
D.
is A.
You said you're going
D?
for D.
Yes, I said I'll be going for D.
Okay. I should drink plenty of fluid to prevent polyhydramnios. Okay. Our sister was saying something.
A.
Yes,
A.
I was saying that I would go for A.
Mm-hmm. You see,
I should
sometimes
avoid
the questions are
gaining.
so simple. Okay. Look at so we are saying A because we think that gaining weight in pregnancy will not cause prolonged or obstructed labor. Is that it? Gaining weight has nothing to do with obstructed or prolonged labor. Is that so? When you choose that, the answer A, that's what it means.
Sir Frank, me, I'll choose D.
D. Look at the word. I should drink plenty
of water to prevent
Does it prevent
polyhydramnios. It does not correlate.
More fluid will even help with amniotic fluid.
Okay.
If you hydrate.
Any other? So we are looking at the one that will not cause prolonged and obstructed labor. So understand the question, know the qualifying or those modifying words, and know what to choose. So if it needs further teaching, it means that it's not going to cause prolonged and obstructed labor. All right? Okay. So as simple as ABCD. Because when you drink, you say, I should drink plenty of fluid to prevent. So you think drinking plenty of fluid will prevent polyhydramnios? And polyhydramnios, is it going to cause prolonged or obstructed labor? All right. I hope it's understandable, right? Okay.
Hello, boss.
Yes, please.
So with the rickets, will the child develop the rickets in utero or what? Because at times growing up is then that you see that they have the rickets. So can you explain that?
Okay. The mother is saying that I should take vitamin D supplement to prevent rickets. Okay. So if you are having what's the name? Ricket. He said it develops when? He said it develops when?
I'm asking if the ricket develops in utero, like before the child is born, or
Yes, yes.
you know, okay.
That you see, it starts seeing it when the child is growing. It becomes more obvious when the child starts growing. But that doesn't mean that we get it after delivery. It's a condition that we get after delivery. You can get it in utero before you are born. Because it's when you get it, once you are born, while you are growing, it becomes more obvious. Do you understand? Because the bones are elongating, and that will become more obvious to see. But if the bones are just small shots during just after delivery or even in utero, it's not quite obvious. Okay, but it becomes more obvious once you are growing. But that doesn't mean that we get it after delivery. Okay. All right. A nurse is preparing to perform vacuum extraction for a client who has obstructed labor due to a face presentation. Which of the following should the nurse take? Select order apply. So the child is coming with a face presentation. And the nurse is preparing to perform vacuum extraction. Okay. And then which of the following actions should the nurse take? Obtain informed consent for the client. Administer prophylactic antibiotics to the client. Apply traction to the vacuum cap during contraction. Release the vacuum cap after every 3 pulls. Monitor the fetal heart rate continuously. Yes. Which one is the answer? I hope. Let me show you this thing before maybe you okay.
Sir Frank, all
Yes,
of them
please.
make sense to me also.
All of them what?
Like it makes sense. Okay. Per my own a little assessment, obtain informed consent. We all know that is crucial in every procedure. So A is good. And then per every procedure, especially if it's invasive, definitely a prophylactic antibiotics is also permissible. Apply traction to the vacuum. Okay. So I would choose, I would choose all that apply. Like A, B, C, D, E.
Okay. Anyway, let me show you something. Have you seen this?
Mm-hmm.
Can you see it?
Yes.
Yes.
All right. So that's vacuum. So if the child is being born, especially when do you use vacuum?
Dilatation.
When do we use vacuum?
When there is full dilatation of the cervix.
Full dilatation.
Yes.
When there's you need to assist the mother to expel the baby. Maybe when labor is prolonged or
I think prolonged and obstructed labor.
Prolonged and obstructed labor. Okay. So, you know, when we are doing delivery, okay. If you see this vacuum, please try to mute. don't let me take you off the page. Okay. All right. One thing that you should know is that when you are doing vacuum delivery, okay, this one is just you are assisting the birth because the child sometimes because of obstructed labor, the child is not able to come, so we have to assist, okay, with the delivery, okay. So sometimes the mother can push, but we just have to help, okay, so that we can pull the head of the fetus, all right, especially in prolonged labor when they're doing the second stage of delivery, or if there's fetal compromise, the mother can push, but the baby is taking long time to come. Okay, there's fetal compromise. You have to quickly deliver. But so this one, it's like the JP that we were studying. Okay, Jackson Pratt. Okay, this one will do what? Suction. Once you apply it on the head, let me show. Let me see if you can see it here. Okay, I think I have some. Okay. All right, so let's continue. I'm not having the picture I wanted to show you. So with this one, once you apply it on the head, it's going to create that suction, okay, on the scalp, on the fetal head. All right, so that this one will just help with what? Pulling the baby out during contraction. So once the mother there's contraction, uterine contraction, with this will help pull the baby out. Are you please getting it? So it works hand in hand. Once the mother is pushing or there's contraction, then this one will also do suction. So every contraction or every push, we do suction so that the child will be pulled out. I hope you are getting it.
Yes, sir.
So sometimes during, let's say, we are having a late decel, okay, or we are having fetal distress. All right, this one we can use. Or even sometimes when we have the mother is exhausted, especially during the second stage of labor, okay, we can use all these things. All right, but know that before you use this one, it's like doing fetal monitoring, internal fetal monitoring. Until there's rupture of the membrane, you can't do fetal monitoring. The same thing applies to this. Okay, you have to let the cervix to be what? Completely dilated. Okay, the cervix must be completely dilated before you can apply this on the fetal scalp. How we get it? Okay.
Yes, sir.
So when the cervix is not fully dilated, we don't usually do it. We don't apply this. Okay. And the membrane must be also ruptured as well. All right. And sometimes you have to see the fetal head, the presentation, the position, everything about the and this one, please. Although this is a question, but before you use this one, you don't use this one on the face of the baby. When there is a face presentation. Please, okay. Because when you do this, it's going to occlude the nostrils, the mouth, and everything. Okay, as well as the eyes. And when we are suctioning, this one can pull the eyes out. You get it, please? So we don't apply it on the face, rather on the what? On the head, the vertex. Okay, or when we are having vertex presentation or head presentation. Please, okay.
Yes, sir.
So when we are having, let's say, face presentation or sometimes brow, okay, like the forehead is showing a lot. This one we don't do it with vacuum extraction. So we also need informed consent form. Informed consent, because we can't go and use this one because it carries risk. So we have the mother needs what? Consent. All right. So please know when it is contraindicated. Okay. When the child is coming with the face, no. Or sometimes bleeding conditions, we can't do. Or even if say the fetus is preterm babies, we can't do. Okay. So know all these things before we do vacuum delivery. Okay, so they place the cap around the fetal head and then just create that negative pressure. Once the baby is there's contraction, there's what's the name? There's pushing. When the mother is pushing, then we do it. Okay, so that's what we should do. Okay, let's go back to the question. So it says that you are doing vacuum. Which one of the following should the nurse take? Prophylactic antibiotics, apply traction to the vacuum during contraction, release the vacuum cap after every 3 pulls, and then monitor fetal heart rate continuously. Which one do you think is important? We should include. Yes, please.
Obtaining informed consent from the client.
Okay.
Then also you apply traction to the vacuum cap during contraction. That is C.
Okay.
Then E, monitor the fetal heart rate continuously. I think it's also correct.
Okay. You monitor fetal heart rate continuously. All right. Okay. Let's see. So if you are doing, obviously, there's what's the name? Which one? Yeah, informed consent. Obviously, we are going to obtain informed consent form, no doubt. Why are we not using antibiotics? What do you think? Let's finish with this question and close. Yes.
Because I think some antibiotics may have effect on the unyet born baby if used, and then the labor, maybe you don't deliver the baby in time.
Okay. All right. And D, release the vacuum cap after every 3 pulls.
Contraindicated.
Contraindicated. Okay. So it says that the nurse should obtain informed consent form before performing vacuum extraction, as it an operative vaginal delivery that creates some risk for the mother. The nurse should also monitor the fetal heart rate continuously during procedure, as vacuum extraction can cause fetal distress because the cap is in there. I please, okay.
Mr. Frank, actually, it's just that NCLEX, you don't question it, but the mother cannot give a consent of the procedure that is contraindicated.
The mother cannot do it.
Yes, we can't give a consent to do a vacuum extraction to a face presentation. So the procedure is contraindicated.
Yes, so that's why I told you that. I initially told you that we don't do vacuum extraction with face presentation. Okay, because we don't want to suction the eyes. We don't want to suction the other organs. We apply it on the, and even sometimes it can cause this thing. What's the name? This caput succedaneum. Okay, or sometimes cephal hematoma, because we are suctioning, we are applying pressure, negative pressure. So we don't do it on the first presentation. But ideally, if you are doing vacuum extraction, you need maternal consent. You understand, please?
I do.
All right. Any question, please? All right. Thank you so much. I have some questions with us. And
Boss.
God willing, we are going to do placenta abruption, placental previa induster. Yes, please.
Yes, please. Can you explain why the D is wrong? I thought maybe if you pull it continuously without releasing for relaxation, it might also injure the baby's head. So can you throw more light on that?
Okay, who can help us? The midwives. Yes.
Please, what is the question?
It's asking of the D, releasing the vacuum cap after every 3 pulls. Is that not it?
That is correct, provided the baby is presenting with the vertex, actually the head.
Please, what is the meaning of the three pulls? The 3 pulls here means what?
3 pulls. Just pulling.
Pull once, and then second, and then third.
Once you are doing
okay.
extraction,
Yeah.
Yes,
so,
to our brother's question, who can help? Yes.
Maybe I don't understand the question.
Is that?
Maybe I don't understand the question, said to help.
Releasing the vacuum cap after every 3 pulls.
So,
Okay.
okay.
This has to go concurrently with the push of a mother. As the mother is pushing, then you are pulling and release when the contractions stop. And then when the contraction comes again, you pull, maybe for the second time. And then for the third time.
Okay, thank you. Someone wanted to talk.
Okay, I was also thinking that probably maybe the more you release it, maybe you may be losing most part of it again if the mother is not contracting or pushing well. So if you release it, probably maybe the head may be going back, or the baby may fall back into the maybe inside.
It's not possible.
Okay.
Okay. Any other? Yes. So you are saying that every 3 pulls you just release. So all the subsequent contractions, subsequent pushing, you're not going to apply the cap. But mind you, the purpose is to hasten delivery. Do you understand? So if during those periods you are not also exerting vacuum contraction, do you think you are worsening the case or speeding up delivery? Are you delaying or speeding up? I hope you understand. Do you understand, please?
Yes, please.
So does that mean that No, I'm not. I'm not still all that clear because my concern is that after you, after you apply the vacuum and you put for some time, I'm thinking that there's a need for you to also release, or is it because they said after 3 pulls you should?
No, this says that once maybe there's mother is there's pushing, okay, and once the mother is pushing, then you apply your vacuum suction. Then once the mother is pushing, you apply. Once the mother is pushing,
Yes.
you apply for the third time, and you stop. So that's why it says release the vacuum cap. So we have to release it from the head of the fetus after every 3 pulls. So once you do it, 1, 2, 3, then you have to release the cap. No. Do you understand, please? We don't release the cap. Don't remove or don't detach it from the fetal head. Do you please understand?
Okay.
Or you're still confused? And brother?
All right. Yeah, I'm getting it.
Okay. Anyway.
Bonjour.
Hello.
Bonjour.
Yes,
Hey,
please.
Debbie, I'm a friend. Yeah, sorry, boss Frank. Please, I want to get this right. It means that if you are doing vacuum extraction during labor, when you apply the vacuum to the scalp of the baby, you do not release the cuff until the vacuum until the process of delivery or delivering the fetus is done, right?
Sorry, we said we don't
Hello.
release the cap
The
after.
vacuum cup.
But then come again with the
Hello.
question. Yes.
Yes, I said I want to get this right, that when you are assisting a mother with vacuum extraction delivery, you are once you apply the vacuum cup, you are not going to release the cup under any circumstance until the baby is fully delivered, right?
You know, this vacuum cap, we mostly release it because mostly the head is delivery of the head is the problem. Delivery of the head is the problem. Okay, that's why the mother will be crying. Once the head is delivered, that's it. Or I'm lying. Ladies, is that not so? Once the head is delivered, the pains will go down. All right? So the main issue is the head. We want to deliver the head. Okay, so once the head is delivered, we release our vacuum cap because the rest, the delivery becomes so simple. Unless maybe there's a shoulder dystocia. And with this shoulder dystocia, we can use this thing. All right. So once the head is delivered, the labor has ended. Or I lie, our ladies.
You
That's the
don't
most
lie.
that's the most
Even with
difficult
a
part.
normal delivery, as soon as you push and the head comes out, that is all.
Yeah. That's the most difficult part for the head to come. Sister, please, do you understand?
Yes, please. So it means when the head is out, you can release the vacuum
Yes.
cap and then continue with delivery.
That's the main issue that we are doing a vacuum extraction because we are
Okay.
getting prolonged labor. The head is not being delivered, so we want to assist with the delivery. Once the head is delivered, the labor has ended. All right.
Yes,
Thank you
please.
for your
Thank you
time.
very much.
Please
Yes, please.
explain point C for me.
Point C.
Yes.
Please read it, please.
Apply traction to the vacuum cap during contractions.
So apply traction to the vacuum cap during contraction. Yes. I should explain the meaning.
Yes, please.
Applying.
I thought you said that the vacuum cap is used when there is contraction.
When we apply vacuum cap during contraction, is like you know that. I hope I showed you the cap. Did you see the cap?
Yes, please.
Yes. So when the mother is pushing, okay, when the mother is pushing, the mother will just then we apply the cap because we want to assist with the delivery. So most of the times, hey sister, sorry, most of the times we apply the cap to the fetal head, the scalp, okay? And
yes,
if the mother is pushing, okay, if the mother is pushing, then we also apply the traction. Do you understand?
Oh, okay.
Once the mother is pushing, we apply traction because you can't apply traction if the mother is not pushing.
Okay.
It's like you are trying to push the baby out of the from that area, okay, the orifice. All right. So when do we have to pull? When the mother is pushing. Once the mother is pushing, then you do traction to help with, so it synchronizes with the pushing. Do you understand?
Okay. Yes, please.
So that is what mostly they do. You understand? So know when with vacuum extraction, know when the vacuum is released. Okay, know when we apply traction. Do you understand?
Yes, please. Thank you very much.
All right. Are you okay?
Yes, please, I'm okay.
So if there's no contraction, if there's no pushing, we don't do traction. You understand?
Okay. Yes, please.
Unless there's pushing, there's contraction, that's when you apply. All right.
Okay.
Thank you so much for your time.
Sir Frank, in this instance, with this question, I want to just be sure. Which ones are our answers?
Which one are answers? Of course, we are going to take informed consent form because we are doing vacuum. It comes with a risk. As I told you, it comes with bleeding issues. It comes with carpal succedaneum, another one, cephal hematoma. All right, it comes with complications. So we have to do consent form. Administering prophylactic antibiotics has nothing to do with this. Okay, we don't administer antibiotics. It's not something that we do routinely. Apply traction to the vacuum cap during contraction. So once the mother is having contraction, once the mother is pushing, we apply. That's when we apply traction. But once the mother stops pushing or there's no contraction, you don't do what? Apply contraction. How does that make sense?
Yes.
Yes. So that's So when we are the mother is contracting, that's when you apply suction. When the mother is pushing, that's when you apply suction. If the mother stops pushing, you also stop. That's when we rest. But we don't release the cap until the head is delivered. And another thing, release the cap after every triples. No. The cap has to be attached to the fetal head until the head is delivered, isn't it? Yes. That's what we do. And number E, monitor the fetal heart rate continuously. Yes, we want to know, is the child, it comes with neonatal complications. And I told you, carpal succedaneum, it can come with bleeding issues, can come with carpal succedaneum and cephal hematoma. All right. So we also have to monitor the fetal heart rate. If the fetus is experiencing any distress, it's a sign of distress, because that's one thing that we use the heart rate to assess. Distress, fetal distress. The heart rate will go up as well as the respiratory rate. All right. So obviously, we are taking A as part, we are taking C as part, we are taking E as also part of answers. You understand?
But
Yes, I
Frank,
do.
please, the answers you showed, it was just A and E.
Pardon?
I said the answers you showed, it was just A and E.
A and
The
E.
C was a part. Yes, please.
Are you sure?
Yes.
Let me see.
Yes.
Okay. Yeah. It's not A and E. Listen. C is part, please.
Oh, okay.
Sorry. C is
That
part.
was why I was a bit confused.
C is
But I
part.
chose C. Okay.
All right.
Sir, please, last question, please.
Pardon?
I
Hello.
did join the class early, but during the
Oh, I started then. Thank you so much for that. All right. So,
Hello, boss.
yes, please.
Hello.
Yes, a concern.
Yeah, yes, please. Sorry for cutting you, but my network distracted me, so I went when I came back again. You were asking about you were asking a question earlier on, but because I went off, I don't know the answer. You were asking a question concerning shoulder
Yes. So
dystocia, or you
I
said
was
what two things would
yes. The most when you are doing when there is shoulder dystocia. Okay. One thing that you can do is that you quickly put the mother, because how are you going to know if there is what? Tactile sign. All right. So once you see tactile sign, the head has been delivered, but the shoulders are not coming. So once you do that, once you see that, you quickly do Mark Roberts maneuver by placing the mother on the like on the not lat like the mother's side will be on the side lining, okay, not complete side lining, because we want, as much as we want to deliver the shoulder, we also want to prevent what name supine hypertension. Okay, so we flex the thighs onto the onto the what, the abdomen. Okay, that is the Mark Roberts maneuver, by flexing the thighs onto the abdomen. Once you do that, you put one hand where on the suprapubic region to unlock the anterior shoulder. Okay, so that is one thing. So doing Mark Roberts maneuver, that the position, and what is a position? Okay, Mark Roberts maneuver is the position. So you put the patient in that Mark Roberts position, and then you apply the suprapubic pressure. So if you see this, that there's shoulder dystocia, that's the first thing to do, not to prepare the patient for surgery. Okay, you want to relieve, because if surgery, you just have to push the baby back into this thing and deliver, or maybe you have to do what's the name?
episiotomy.
Yes, but even that, with this, it just the shoulders are locked by the bones. But so the first thing to do is Mark Roberts position, and then you apply fundal pressure. And once you do that, you have to be monitoring, because we said contraction is contraindicated in central in shoulder dystocia. No contraction. It's contraindicated, highly contraindicated, not something that is unnecessary. It's highly contraindicated. So you don't allow the mother to push. If there is oxytocin ongoing, if there's any hypertonic, you just have to what? You just have to stop and monitor the contraction. Know the duration of contraction. Know the frequency of contraction. Know the contraction. Okay, so that because if there's ongoing contraction, is worsening the case. So you just have to let the mother do mouth breathing. Okay, breathing exercise, and then you monitor the fetus as well, because that the heart rate, because there could be deceleration. Okay, fetal distress. All right, so that is what I said. I hope you get it now. All right, so we are going to tackle on this thing, shoulder placental abruption. And I was asking what is the another name for this?
Premature. Okay.
Pardon?
Premature separation of the placenta.
Premature
separation of the placenta.
Before delivery.
Separation of the placenta. Okay. Any other? Any other? Placenta abruption is what? Abruption.
Separation of the placenta
Abruption.
before the onset of labor.
So another name is what? Abruption what? Placenta. Are you getting it?
Yeah.
Yes. So that's what you should know. Okay. When we talk of placental abruption, when it comes from the word abrupt. Abrupt means what? Sudden. Something that occurs suddenly. All right. So if we are having premature separation of the placenta, this one is normally placed at the fundus. Okay. High in the uterus. All right. And if it separates itself from the wall of the uterus after 20 weeks or before birth, okay, what is going to happen? Because the fetus rely
On the
placenta for oxygenation. All right. So if there's premature separation, where is the fetus going to get oxygen? So fetal oxygenation will drop. Okay. Once it is detached, we are going to see what? Hemorrhage. All right. And this is obstetric emergency that you should know. So it's part of the obstetric emergency conditions that you should know. So the placenta has got abruptly detached from the uterine wall. And we are going to make a comparison with this and Previa. Okay. So please take note of this. All right. So if you have premature separation, all right, of the placenta, there's fetal decrease of fetal oxygenation. What is going to happen to the child with fetus? So that's the areas where you should think. There's ongoing bleeding, and what will happen if there's blood loss, like hemorrhage. All right. So that's what we are areas that we should focus on. How we are dealing with this condition. All right. So what are you going to do? Something that is abrupt is painful. So that's why when we are comparing this to Previa is painless, isn't it? But with this one, because it's abrupt separation, sudden separation, it becomes painful. So know that abrupt separation, placenta abruption, or abruptio placentae is painful. So the mother will be bleeding because it has detached from the wall So the mother will be bleeding. And once the mother is bleeding, blood will be collected in the what? In the uterus. And that will make the uterus rigid and bud-like.
Yeah, concealed bleeding.
Yes. So if you are having this, and this one, when you say concealed bleeding, it depends on the whether there's complete rupture. Complete separation.
Mm-hmm.
Okay. If it has separated completely, you are not going to see concealed bleeding. But if the center of the placenta has detached with the edges intact, okay, this thing is only the central area is detached with the edges intact. This one we are going to see or conceal or bleeding.
Bleeding. Okay.
All right. So as I told you, the fetus depends on the placenta for oxygen. So once there is problem with placenta, what kind of deceleration are we experiencing?
Late deceleration.
Late deceleration. We are going to experience late decel. So please take note of that because we are dealing with placental issue. So once it is placenta is late. So late deceleration, and that will cause fetal distress. Okay. And once it's painful, we are going to see severe abdominal pain or back pain. And there's bleeding, signs of shock. All right. And if you are seeing blood, you are going to see blood. But this kind of blood is dark in color. Why? Because note that the placenta is situated up, that's high. Okay, it's situated high in the fundus. So before the blood will pass through all the way from the uterus down to the perineum, all the oxygen, the other, what's the name? Oxidation has already taken place. Okay, so it will make the blood dark. Unlike previous, where the placenta is just at the edge or the entrance of the cervix.
Below the uterus.
So, yes. So once there's separation, okay, blood, we'll just see blood quickly. So blood will be seen quickly more than the one that is situated up high in the fundus. So know the color of the blood when it comes to previa and abruptio. So abruptio, because this one, placenta abruptio, placenta is that's situated at the fundus. It's a normal place for the placenta. But with previa, it's abnormal situation. Okay. So once the blood will flow from the uterine wall up high in the uterus, through the uterus wall, and then down to the perineum, or the oxygen has been used, or the oxidation has already taken place. So we see the blood to be dark and very painful because it's abrupt. All right. And if bleeding is high in the uterus, all right, or it's minimal, there can be an absence of visible blood. That's what I told you. Okay. So if very high, then that's why we are going to see that rigid bud-like uterus, because the blood is being collected there and it's not flowing. And if it happens like that, you are going to see minimal bleeding. If it's only the center, the central area of the placenta has detached, you are going to see minimal bleeding with bud-like uterus. But if it has separated completely, you are going to see more bleeding. I hope it makes sense.
Yes, sir.
All right. So that is what we are saying. So increase in fundal height if there's what? Concealed bleeding. Because there's concealed bleeding. The central area of the placenta has detached and blood is being collected there with hematoma. So you see the abdomen increasing in size. So that one, it will increase on the fundal height Okay, and this increase is going to be sudden increase. It's not being aligned with the normal gestational age. Oh, we are okay.
Yes,
All right.
yes, sir.
And what are some of the risk factors? What can cause the placenta to detach? Number one thing is chronic hypertension. That's the biggest risk. Because with hypertension, there's going to be decreased blood supply or flow to the uterus through the placenta. And that one will going to cause detachment. When there's preeclampsia, it is symptom. Constriction of blood vessels leading to inadequate supply of blood to the placenta. Okay, and that's the cells. If the placenta is not receiving blood, what will happen to the cell? They will die off. Once it dies, then it lose its attachment to the wall of the uterus. Okay, if there is trauma or those men who have been beating their wives, domestic violence, all right, you should stop if a woman is pregnant. That's why once a woman is pregnant, we say this one is what for the government. Okay, if you lay your hands on the person, you'll be in trouble. So cocaine use, smoking is also one of them. And when we are doing augmentation, with augmentation, you are using oxytocin, okay, to increase. And once there's oxytocin ongoing, contraction, okay, and if there's contraction, there'll be decreased blood flow to the uterus, causing detachment or premature separation. Premature separation of the placenta. Okay, so that is what is going to happen. All right. So, what are we going to do?
Boss Frank,
Yes, please.
please, before you move on, I just want to be clear. Is there any difference between the chronic hypertension and preeclampsia?
Yeah.
Yes, there's difference. With chronic hypertension, the mother, the pregnant woman, they usually get it before they have
Before pregnancy?
yes, before they have the blood pressure before pregnancy.
And the preeclampsia one develops as they are progressing through pregnancy, right?
Yes, so hypertension can cause preeclampsia. Okay. With this, we are preeclampsia is just when there's still the problem with the uterus. Preeclampsia all result from the uterus. The placenta. Okay. If there's placental, you see, the placenta is attached to the wall of the uterus. Okay. So if there's any problem, if there's inadequate blood supply to the uterus, okay, that one is the cell is going to die. And that one would cause a whole lot of cascade happening, which will result in bleeding and those stuff. And if not care is not taken, it cause because there's blood pressure, increase of blood pressure. Okay, and that is going to have effect on the brain, on the heart, as well as there can be bleeding as well. Okay, so preeclampsia can lead to bleeding. I hope you know that.
Yes, sir.
Yes. So
Please,
when we talk about that.
But you treat preeclampsia later on, right?
Sure.
So let me take it like that. Maybe when we get that, I'll understand.
Yeah, you understand. Don't worry. Okay. But it's part of the hypertensives in pregnancy. Okay. All right.
But please, and I think when there is high protein too, plus hypertension, that one too can lead to preeclampsia.
When there's what?
High protein.
High protein.
What are signs of preeclampsia?
Yes, when there's high protein plus the hypertension.
All right, but it's not with protein. When there's proteinuria is not currently. There has been some modification with the diagnostic criteria. All right, when you take preeclampsia, proteinuria is not considered one of the hallmarks of diagnosing preeclampsia. So know that.
Yes, there are 3 cardinal signs.
Yes. So know that
Oh, okay.
proteinuria is not cardinal. Okay. Cardinal thing to diagnose preeclampsia. We'll talk about them later. Okay. All right. So with this, there's premature separation. Okay. The fetus is having distress. The abdomen is becoming board-like. So what are you going to do? Your fetus. You have to assess, is the fetus stable because it's not receiving blood? All right. You have to monitor the heart rate of the fetus, the vitals of the fetus. You have to monitor. Okay. And this one, because there is inadequate supply of blood, you have to place the mother in a left lateral position because there is decreased uteroplacental perfusion. And it's one of the ways of managing late decel is to do what? Lion. I hope you remember. Lion. L-I-O-N.
Yes.
Just
Yes, sir.
lateral. And because we are thinking of the fetus to get blood. So how quick can we get blood to the fetus? Quickly, you put the mother in left lateral position just to maximize perfusion. Or if that's not feasible, then we have to do what? Trendelenburg. Okay. Position. So Trendelenburg position. I hope you know Trendelenburg.
Yes.
Mm-hmm. So we put the mother in Trendelenburg position just to also help with this. Okay. All right. So we have to maintain bed rest. With bleeding, please take note. With bleeding, exercise is not the ideal. Whenever there's bleeding, that's why in preterm, if you are at risk of preterm, those who are in class, in discussion class, we just recently learned preterm. When there's preterm, you don't allow the mother to do exercise because when you do exercise, it complicates things. Okay, because with exercise, there's vasoconstriction. Okay, and this one will complicate the condition. So with placental abruptio, you don't want to do exercise. So we have to maintain bed rest. Okay. Once you are maintaining bed rest, know that when the uteroplacental perfusion is cut off, it is going to minimize blood flow as well as what? Oxygen. So we have to give oxygen for the purpose of the fetus. IV fluids is like the lion. Okay. Why do we need corticosteroid? For lung maturity. Please take note. In preterm, we give corticosteroid. Okay. In premature separation, we also give corticosteroid. Because if it's not, the lungs are not fully matured, especially if the gestational age is less than 34 weeks. Less than 34 weeks, please, we give corticosteroid. An example is Dexa and what? Betamethasone. Okay, so please take note of the timing here. 34 weeks, less than 34 weeks, you have to give Dexa. You have to give betamethasone. Okay, and why do you think ROGAM is important here?
There might be a mixture of
Yes, because with all bleeding, that's why recently when we were learning amniocentesis, we said that we have to what? Prepare for ROGAM administration because there's going to be bleeding. There's going to be bleeding. All right. Once bleeding is suspected, please, you have to prepare for ROGAM. Okay. You have to know the amount of blood loss. How are you going to know? How are you going to know the amount of blood loss? And with this one, we
question.
Yes, please.
Yes, so with regards to this one, the immunoglobulin that we have to give, is it compulsory for every um, pregnant woman with this kind of condition? Because yesterday
If
when we were
the
talking about
mother is RH what?
resource negative, okay.
Yes. So that's the protocol. If the mother is RH. So that's why sometimes when the question is given, if it comes in as a case of a case scenario, you have to read your background or history. Read every history before you take any action. So with blood loss, you have to also monitor your H&H.
Boss,
Yes,
please, what if Rogan has been given already?
Rogan has been given already, like
maybe around the 20th week or something.
with this, whenever there's bleeding, we give. Okay. If like let's suppose this one we give. Okay. And so one thing that you should take note is that whenever there's bleeding and we suspect the mother is result negative. Okay. And because we want to prevent, because they will only sensitize once there's a miss of blood. So we have to give RH. Okay, negative. We suspect that there's going to be a miss of blood. All right. So we have to also know the H&H. What is the H&H? H&H means
Hemoglobin.
all right. What do you think will be the level? Will be high or low?
It will be low.
Low. So we have to wait. Yes, please.
Sorry. So please, does it mean the Rogam can be given more than once?
Yes. Rogan can be given more than once.
So if it has been given at 28 weeks, and then maybe say 30 weeks, the abruptio okay, they can still repeat it again.
Yes. Okay.
Hello.
Wait. Yes, please.
Wow. Okay. Thank you, sir.
All right.
All right. Thank you.
So,
please, what did they say the H&H is? Please, I didn't hear.
Hemoglobin and hematocrit.
Okay, thank you.
All right. So with the pad, one way of also assessing blood loss is to weigh the pad. So you know that 1 gram of weight is equivalent to what? 1 ml of blood loss. So that's how we estimate blood loss. So always weigh your pad to estimate blood loss. You have to also know the heart rate and the blood pressure of the mother. So this one, we are monitoring the mother as well as the fetus. Okay, in emergency situations, we have to do CS. Okay, if the fetus is alive, but signs of distress is suspected, please know this. If the fetus is alive, there's placental abruption. All right, the fetus is alive. And if that, because we do all this assessment because there can be complete
Please,
separation.
I didn't hear the estimate. The blood estimate, the weighing.
I'm saying 1 kg to 1 ml.
1 gram.
Yeah, sorry, 1 gram. 1 gram, sorry. 1 gram. So when you weigh the pad and the pad weighs 1 gram, it's equivalent to 1 ml of blood loss. Okay. Just 1 ml, not 10. 1 ml. So 1 gram to 1 ml. Okay. So we are saying that before we do CS, you have to know, is the fetus alive, as well as is it showing signs of distress? Because if the fetus is showing signs of distress, especially if it is so severe, it means that there's a complete separation. For partial separation, the fetus can be sustained till delivery. But if the fetus is showing signs of distress, Please don't wait for because assuming there has not been this thing, because this one is premature rupture. If there's not dilation has not been fully achieved. We are not having 10 cm dilation. We are not having what's the name? Rupture of membrane. Okay, you have to prepare the baby for CS. All right. Or we are having excessive bleeding. You are having signs of shock. The mother obviously can't push. Okay. Your heart rate, how will you know that there's signs of shock? Heart rate high, BP low. Vaginal delivery, if the fetus is stable. So if the fetus is stable, no signs of distress, please, you have to do normal delivery. All right. We need to also insert catheter. Because there's hemorrhage, you have to assess renal perfusion. So passing of catheter is important here. All right. And you also have to administer oxygen. As simple as that. But oxygen here is via face mask. Okay. Are you okay? Any question? Any addition?
Please, I have a question.
Okay.
Yeah, I understand what you have taught so far, and I want to find out that if the child, we said that it is from after 20 weeks and then before birth. So if the child is around 21 weeks, I believe that survival rate would be low if the child is born. So if there is complete placenta abruptio, what happens to the child? Do you still deliver vaginum or you go through CS, or how is that managed?
If there's complete separation.
Yeah, if there is complete separation, I want to know if the child is not able to, it hasn't gotten to the stage where the child can survive outside the uterus, like 21, 22 weeks. What happens? And if there is no complete abruptio, but part is attached, part is
separated.
Probably what happens to the child too?
All right. So if I hear you right, you are saying that if the child is like preterm, extreme preterm, right?
Yes, please.
And there's complete rupture. Is that not it?
Yes, please.
Complete separation. Yes.
Yes,
This
please.
one, we have no option than to deliver. Because the child will be showing signs of distress, a severe one. And if you are delaying, what's the name? You are delaying delivery. You want the mother to deliver per vaginum. Please, it's not going to be possible. Unless maybe we augment the labor. Oh, you get it. You have to, maybe we augment it.
The life of the mother is going on.
Pardon?
I say at this point in time, even if the baby is not viable, the life of the mother, so that's why you see they mostly go back for CS because
Yes.
bleeding is the mother is at risk too of losing her, going to shock.
So we have to know the mother state, the state of the mother as well as the fetus. That's why I said emergency delivery. If when we take fetus is showing signs of CS and the mother showing signs of shock, this one emergency CS. So once there's complete complete separation and the fetus is showing signs of distress, premature, when there's premature like preterm like this, you may not get rupture of the membrane. The cervix might be intact. Okay, because this one is just separation. We are not getting premature labor. with premature labor, we are having dilation, isn't it? But this one, we are not having dilation. So it could be that the amniotic fluid, is what is there. It hasn't the membrane
Placenta
has not
abruption.
ruptured, and then the cervix is intact, no dilation. So over here, there's no way you can do. You have to prepare the mother for vaginal delivery. You have to do CS. All right. Once the baby is showing signs of distress, you have to do CS. Okay. So that's
Okay.
what we are not going to give this thing corticosteroid here. There's no point of giving corticosteroid. Okay, because we cannot delay CS or delivery.
Okay.
I hope you understand.
Yeah, I understand. So it means it depends
Frank,
on the
please, I don't
assessment at the
understand.
time.
You don't understand. What's your point,
Yes,
please?
because you said we give corticosteroids to mature the fetus lungs, right?
Mm-hmm.
So at the time that the baby is immature, and then there is complete detachment as well, wouldn't there also be a need for, like, I want to know where you draw the line that, okay, this is where I'm not going to give the corticosteroids, and then this is, because if it's for the maturity of the fetus, and then the baby is preterm as well. Like, I don't understand why you don't give the corticosteroids. If you can elaborate further on that. Do you get my question?
What I'm saying is that if the mother is showing signs of shock, the fetus is showing signs of distress.
Distress.
Okay, look at the term. The mother showing signs of shock, the fetus showing signs of distress. And do you think doing CS and giving corticosteroid, which one is important?
Yes.
CS. So over here,
Yes.
we choose CS because when are you going to do when are you going to mature the lungs? Because this was an emergency. This one is an emergency. You are maturing the lungs. All right. But note that the fetus is not getting oxygen. The fetus is not getting oxygen because there's complete separation.
So let me get this right. So does it mean that there is a clause to this? If there is partial separation, then that one you can give corticosteroids.
Yes,
And then if
that's when you
there is
show
total separation.
Yes, because that's where you are sure that the fetus is not showing signs of distress. So we give corticosteroid just to mature the lungs. Okay, we give corticosteroid just to mature the lungs. And that's when the fetus is not showing signs of distress and the mother is not in shock. Over here, once the mother is in shock, severe shock, and the mother showing signs of distress, know that the fetus is not getting oxygen. The fetus is not getting oxygen, 0% of oxygen, because it's fully detached. So over here, you have to prepare the mother and deliver and save the life of either one or two of
So,
them.
Mr. Frank, does it mean that with a partial abruption, you don't, like, there's no delivery?
There's no delivery. There will be delivery. You deliver.
Okay.
You usually deliver.
Yes.
Because partial, know that the mother is bleeding in utero. Either it's concealed or there's minimal bleeding in the vagina. And you are saying you are maturing the lungs, you are maturing the baby before delivery. Though you are going to mature the lungs, but are you going to mature the baby? No. because there's ongoing bleeding. Do you understand, please?
I
Okay.
still don't understand. I'm not too
No,
okay, but you let's continue. Maybe
please,
with time
I
because
want to
No,
ask a
what?
you see,
question.
Let me clear your doubt. What is
Boss
it you don't
Frank,
understand?
because
Please
to
let me
every
understand.
action with there may be I have not really listened well or I don't understand because to every action there is a end reason why we give. So you let me just ask this basic, maybe you call it silly question asking. Why are we maturing the lungs in the first place? Maybe if I get the answer to that, it
We
might
are maturing the
you know
lungs if the fetus is less than how many weeks?
34.
24 weeks.
34 weeks.
Boss Frank,
Please, also, the
please
reason why you mature the lung is that we call something surfactants. They help in respiration and filtering of either liquids and other things.
Yes, I
When
know
the
that.
fetus are
Yes.
not fully mature,
Boss Frank,
Yes, please.
please let me say this. Maybe will help our sister.
Okay.
So, per my understanding, the corticosteroids being given, it is not going to mature the lungs right away. As in, you give it, and then because it is given IV, it has matured the lungs. It takes 24 to 48 hours for the drug to mature the lungs of the child or the fetus. And even that, the child's chances of survival per preterm, the child has to be 24 weeks and above. Now, the question I asked, to which he gave that answer, was that the child is 20, or the fetus is 21 weeks, and there is total abruption. It means that the mother is bleeding at risk of hypotension, and then this child has lost contact with oxygen. There is no oxygen supply to this child. So the mother is at high risk of bleeding to death. The child you are trying to protect, so you want to give this corticosteroids for the next 48 hours, is also already not going to get it, probably because the placenta is totally detached. I don't know if it helps, but then with this, it means that it is an emergency. The mother is bleeding and the child is not getting oxygen. And again, the chance of survival is almost zero because this child is 21 weeks. So if there is no imminent need to deliver the child, then maybe the child is not in distress, the mother is somehow managing the situation, then you can, or the vital signs are stable, then you can say that, okay, let me give corticosteroid and then do vaginal delivery. But in the space where the mother is running into hypotension with tachycardia, there is late deceleration with the fetus, you have no business going to administer corticosteroids and then waiting for that length of time to conduct vaginal delivery. That one, emergency CS is imminent to save the mother because this baby has almost zero chance of surviving.
Yes.
Thank you.
Good.
Thank you. So if I understand, the emergency aspect is more centered on saving the mother as at that time, though the baby could be saved as well. So that is why there wouldn't be any need for corticosteroids, if I should say. Is that
Yeah,
so?
so
I understand your submission. Uh-huh.
yeah, so I would say it depends on the assessment at the time. But with what I gave, the assessment details I gave, this child will not survive. So there is no point you giving
Exactly.
corticosteroids. Yeah. Thank you.
Yes, thank you.
All right. Oh, everyone is clear.
Boss Frank,
Yes, please.
please. So if I understand clearly, that means if there is a partial detachment and the baby is not matured enough and the mother is stable, we give the corticosteroids to buy some time for the baby to mature before we can deliver. Is that it?
Exactly.
Okay. Thank you.
All right. Thank you so much. So that is. So know when to give corticosteroid, know when to do emergency CS, as simple as ABCD. Okay. Once the mother is stable, we can buy time for the baby to mature. You have to go ahead and give corticosteroid. But if not, there's complete and signs of shock, signs of distress, because know that oxygen has cut off completely.
Hello. Hello,
Yes, please.
sir. Okay. I also want to understand this. So talking about buying time for the baby, is it that the corticosteroid is coming to perform like coming to function like a placenta to the baby?
No. No, corticosteroid is given for lung maturity. Know that at less than 34 weeks, the lungs of the fetus have not fully matured.
Yeah.
Okay, so if the lungs have not fully matured and you deliver, the baby can't breathe. There's going to be problem with that, and that will result in respiratory distress, acute respiratory distress. I hope you're okay, because the surface is not because when there's breathing, the breathing mechanism, when you breathe, the lungs expands and closes, expand and closes. With the fetus, if the lungs has not fully matured, it can't perform that function. So the corticosteroid is given to mature the lungs. As simple. That's the purpose of giving corticosteroid, to mature the lungs if the fetus is less than 34.
Okay, so in case of in case of partial separation, after giving the corticosteroid, how long are we supposed to wait before delivering the baby?
Yes, I think our sister also contributed that. With this one, ideally from 24 to 48 hours, you can deliver.
Okay.
Okay, you can deliver. So that is what you should know. All right.
Thank you.
So,
boss, I think one simple thing also is that we should all know that if the placenta is partially maybe separated, that is where even giving the betamethasone or the corticosteroid can work. But if it is completely, separated, there's no way it will work. It will not even get to the baby, let alone to help expand or mature the lungs.
All right. Thank you so much. Okay. I hope everyone is clear now. Okay. Let me ask the class. Can this lead to DIC?
Yes.
Yes, it can.
Yes.
Okay.
Yes, it can.
Very good. Because I think I told you that with placenta issues, that's why even in preeclampsia, I told you that it's placenta issue. The whole thing happens because of the placenta. The same thing with this placenta abruptio. So this one can lead to DIC. Oh, that makes sense.
Yeah.
So please know that this one can lead to DIC. But the one thing is that if with DIC, placenta, it has something that we call thromboplastin. Are you following? It has thromboplastin. Okay. And if with placenta, if there's what's the name? There is premature separation of the placenta. Okay. Because the placenta has separated from this. Because already the placenta is firmly attached to the uterus. That's one thing. Okay. And know that the placenta, as I said, it has that thromboplastin. Okay. they are released. Okay. And this, when they are, before they can be released, it means that there has to be what? Separation. And once they are released, this thromboplastin, they come, look at the word, thrombo. Thrombos means what? Thrombos.
Clot, blood clot.
Okay. So thromboplastin, all right, this one will enter through the mother's maternal circulation, okay, and result in clotting. Okay, this one results in clotting. And once the ongoing clotting, whose mic is on and causing disturbances? Let me see. Once it's causing clotting, what will happen to the platelets? They'll be used up. Because whenever there's clotting, I think recently I told you that all the things that we use for clots, for example, we use fibrinogen. Okay, because once platelets forms, the fibrin will come and form a mesh around it to make it solid. Okay, so fibrinogen, fibrin, platelets will all be depleted. Who is that? Let me see.
It's Franklin.
Who is that? I will remove you so quick. Okay. Let me make it this way so that I will see the person. So once there's ongoing bleeding, clotting, and all the clotting factors, all the platelets, when they are used up, what follows? Bleeding. Are you okay? Because these thromboplastin that have been released, because that's why God is so good, because the placenta contains this thromboplastin, so that after delivery, they can be what? Clotting.
No.
Okay, they can be blood clot. You wouldn't bleed to death. That's God. Okay, so once there's thromboplastin in the placenta, and once they are separated, and know when they are released, if there's detachment, because that's when the clotting will be needed. The blood clot will be needed after delivery to help with what? Clotting, so that we wouldn't bleed to death. So once the placenta is separated and thromboplastin released, it enters through maternal circulation. And this will cause what? Clotting cascade. I hope we are okay. So it means that all the things that are used for clotting, an example I made mention of what? Platelets. It will be depleted, go down, because that is what is being used for clots. Fibrinogen, as I told you, fibrin, that's what forms the mesh. So that one will also what? Go down. And all the clotting factors will go down. So if you want to know, is it DIC or what kind of bleeding is that? What problem is resulting? Check your labs. Check your labs. So if you see that platelets going down, fibrinogen going down, other clotting factors, they are also going down. Okay, know that this is leading to what? This premature separation is causing DIC. I hope it makes sense. Hello?
Yes, sir.
All right.
Yes.
So that is what is happening. So if there is clotting, finally, all these clotting factors I mentioned will be used up. And then mother also enter into a phase of bleeding. So DIC is clotting and bleeding occurring at the same time. So once the mother enters into that bleeding phase, then you see that if there's the mother is having IV line, you see that that place will be bleeding. Okay, if the mother, you see, you check the mouth of the mother, you see that the mother is bleeding from the gums, the mother is having excessive vaginal bleeding. Okay, the mother is having petechiae. Petechiae is just a sign of bleeding. I hope you know petechiae. Ecchymosis. All right, they are all signs of what? Bleeding. And if the mother urinates, there's blood. All right. After delivery, you see that the mother is having postpartum hemorrhage. The mother is hemorrhaging. Okay. You are seeing that even after we've done surgery and we are not able to control bleeding, know that the mother has entered into DIC, or the mother is having what? DIC. Oh, that's okay. So that is what you should know with DIC. Okay, know what clotting factors that will go down, all right, and know what are going to go up. So when you check PT, what is going to happen to it?
To go up.
Yes.
Long.
Yes, it's going to be too long. It's going to go up. Okay. When you check APTT, what is going to happen to it?
It will also go
up.
Go up.
High.
When you check D-dimer, I think last time I told you, D-dimer is also one of the things that we use.
the clotting enzyme. So it will
that one
also go up.
Will go up. And your hematocrit, hemoglobin, platelets, fibrinogen, the clotting factors will start going down. So once you see this extreme range, that means that is developing DIC. I hope that makes sense. So that is what you should know. So DIC has to do with clotting, bleeding occurring at the same time. So once you know that the mother is having signs of premature rupture, where we are going to see the body like the other signs and other signs, but know that DIC can be a complication. So read your labs well, know the history well, and manage the case accordingly. All right? So that's what I want to tell you. Okay. What will happen? DIC, bleeding from IV site, petechiae, hematuria, clotting time prolonged, platelets, the one that you use for clots, and fibrinogen, low. PT high, APTT high. Okay? And you have to do coagulation studies. When you say coagulation studies, that is what we are looking at. You monitor your APTT, that activated or partial thromboplastin time. You monitor the PT, you monitor the fibrinogen, know the platelet level, know clotting time. That is the coagulation studies that you're talking about. So it's essential to monitor for coagulation studies. Okay, know your urine output, because in DIC, because there's bleeding ongoing from the orifices, okay, it's going to decrease blood flow, or it's going to decrease, going to cause a decrease in what? Renal perfusion. Okay, there's going to be signs of shock. So when you see that the mother is having cold, clamp skin, okay, mental, and then because signs of shock, there's low blood flow to the brain. Okay, that will alter the state of the mother. All right, pallor will be there, hypotension with tachycardia. Okay, and it will lead to renal condition. Okay, creatinine very high. That means it's also developing into what? AKI. Okay, and postpartum hemorrhage, which of course will be seen as what? Body uterus. Because know that in placental abruption, we are having rigid bud-like uterus. If the mother enters into postpartum hemorrhage, and this one, the mother has what? Delivered. Okay, he has delivered. And once there's delivery, the uterus, instead of contracting, because of hemorrhage, the uterus will be bulging. So what are you going to do? Between giving fluid and massaging the uterus, what do you think is important here?
You must.
You do what?
You massage it.
Uterus.
Okay. So someone is saying between massaging the uterus and giving fluid, massaging the uterus is important. Any other opinion?
But Frank,
Yes.
I think that since if there is signs of shock, especially with regards to low BP, I will set up fluid, then I'll go on to massaging the uterus. I think that would buy me time too. It would increase venous volume for maybe adequate organ perfusion or adequate circulation. Then I'll go ahead and then massage the uterus as well, because the
Okay.
massaging is also to help to expel some of um, um, the bleeding, the bleed, and also to assist in contraction as well. So that is what I would do.
All right. Any other? Yes. Any other?
Same with me, I go with her point.
You go
Because
with?
I go with her idea of put IV line, because for the uterus, even the mother herself, you can advise her to help also to stimulate the uterus, giving uterine massage while you can be putting the IV line, especially when you don't have enough personnel.
Okay. All right. So one thing is obvious. The whole problem is resulting from the uterus not contracting. That is causing the bleeding. That is causing the hypotension. That is resulting in tachycardia. So before you give fluid here, please massage the uterus. Massage the uterus to stimulate contraction before you give blood, because the cause is not tackled, which is body uterus. And body uterus, once the uterus is body, bleeding will be ongoing. Massage the uterus and give you fluid. So that's the cause. The cause is that we're having body uterus. And that is resulting in bleeding. That's resulting in hypotension. So once you massage the uterus.
So, Sir Frank,
yes,
sorry
please.
to interrupt. So, in this case, I think we are also since we are dealing with complications. In this case, can we refer to this postpartum hemorrhage bulging uterus as atony, uterine atony?
Yes, uterine atony is, there's no tone, there's no contraction. Atony, absence of tone. So
yes,
tone, atony. So if the uterus is bulgy, okay, that means there's no tone.
So in this case, if maybe we come across some of the complications, aside from the DIC, we can also equally use uterine atony as well.
You can use what?
Like, I just want to ask and then be sure that since we are using the body uterus, can we use uterine atony as part of the complications of the abruption that we are talking about?
Like uterine atony as complication of placenta abruption.
Yes, I'm asking.
Okay, so uterine atony is just yes. So if we have this thing what's the name? Placental abruption. That one will cause the postpartum hemorrhage. Okay. And once there's postpartum hemorrhage, that one will also lead to the uterine atony. So uterine atony will be a sign of the postpartum hemorrhage. Because once there's detachment, the first thing is the bleeding, which will happen first. So once there's ongoing bleeding, then the uterus, and then the ongoing bleeding will lead to the hemorrhage. That hemorrhage will lead to the atony. So atony will be a sign of the postpartum hemorrhage. So if you want to say it's a complication, yeah, because it's a sign of also a postpartum hemorrhage. All right.
All right, all right.
Okay.
I asked this because of the body uterus, like it was
Yeah, sure.
explaining widely what the atony is all about. So I
Okay.
was just
All right. So please know that I've already told you. Petechiae, okay, and ecchymosis. Apart from these obvious signs, know that in DIC, know the labs that is going down, know the one that is going up. So the one that will go down is those that are used for clotting. I hope you get it. That's the fibrinogen, the clotting factors, and platelet. They are all used for clotting. And this will go down. Okay. So know that. Okay. And know that the rest, the dimer, APTT, PT, they also will go up. I hope that makes sense. Are you okay? So over
Yes.
here, we are going to do a whole lot of management. We are
May
going
I
to
ask something first, sir?
Pardon?
Hello.
Yes, please.
I would like to ask something, sir, on complications
Okay.
of abruptio placentia. Whether these nursing interventions that we are doing, is it after the cesarean section, or how
Are you
do
talking
we
about
go about? Yes, abruptio, where we'll be massaging
Yes.
the fundal. It's after cesarean section.
This massaging the uterus will come when there is, especially in postpartum. Okay. Postpartum, because postpartum, we are having, what's the name? What's the name? Bleeding. Okay. But if you want to deal with the hemorrhage that's on with and the other sign that's ongoing, I told you that we are dealing with bleeding. So once there's bleeding, what are we going to do? What are you going to do? We think of giving oxygen. We think of giving fluid. We think of giving blood products. Okay? We think of giving other medication for bleeding. An example is what? Medications.
Exactly.
Yes, so we give tranexamic. I hope you know tranexamic acid.
Yes, boss.
Yes. So mostly we can use them if after the delivery and the mother is still bleeding, you can give tranexamic acid because that is going to prevent or inhibit the what's the name? Fibrinolysis. Okay, because with the bleeding, the fibrin that forms the mesh to make the clot solid. When you give tranexamic acid, it's going to inhibit the breaking down of the fibrin. So we say it inhibits what? Fibrinolysis. Okay, so that is what this thing tranexamic acid is going to do. So if it inhibits fibrinolysis, which means that we have to monitor for sign. We have to, what are you going to monitor for? What are you going to monitor for? There's clotting ongoing. There's bleeding ongoing. And because of the bleeding, what is causing the bleeding? If there's fibrinolysis is just the breaking down. And the fibrin, I told you, is the mesh that covers the clot. Okay. And if there's some cascade ongoing and there's breaking down of the fibrin, there's ongoing breaking down, what do you think will happen?
Bleeding.
Bleeding. Okay. So when we give tranexamic acid, it's going to inhibit the breaking down. So it means that when there's fibrin has been formed, the mesh has been formed, it is not going to break down. So what are you going to monitor?
Clotting.
Very good. As simple as ABCD. Okay. Notwithstanding, you should also monitor for bleeding because you want to know if it's working or not working. You monitor for bleeding as well as you monitor for clotting. Signs of what? Thromboembolism. I hope that makes sense.
Yes, sir. Thank you very much.
We also give the desert, we give the, what else did you mention? Betamethasone. Okay. And that one, we said if the mother is, the fetus or the gestational age is less than 34, to mature the lungs. Okay. To mature the lungs. That's what we have to know. But once you are given corticosteroid, what are you going to monitor for? What are you going to monitor for?
Infection.
Okay. But that infection, very good. And I hope when it comes to discussion page, they have a term. That is the 7S, right? So we are going to monitor for if the mother will be having hyperglycemia, because we know corticosteroid increases blood glucose. All right? That's what we have to monitor. Are you please okay? That's what we have to monitor. And we also know if there's signs of infection. And another thing is that we are going to give Maxoff, two of us. We are going to give Maxoff, two of us.
For the preeclampsia.
For preeclampsia. Okay. And if there's the mother, the fetus is mostly less than 34, preterm. Because you do know that Maxoff is a neuroprotective med. Are you aware? Neuroprotective. It protects the brain of the child. Okay. Apart from being used for preeclampsia. All right. So that is what you have to know. But once you are giving Maxoff, you monitor the respiratory rate. Okay. You monitor if the deep tendon reflexes are there. You monitor the urine output. Very important. Urine output. Okay. So respiratory rate will go down, and Maxoff, once the respiratory rate is less than 8 and below, we don't give. Okay. If your urine output is less than 30, we hold. You have to know deep tendon reflex before you give Maxoff. Okay. And if you are giving Maxoff, the antidote for Maxoff is what?
Calcium gluconate.
Calcium gluconate. So always before you give Maxoff, please, it is important, it is essential, it's your priority to get Maxoff. Please, before you give marks off, it is your priority to get calcium gluconate standby. All right. So that is what we have to know. Let me ask you, are we going to give tocolytics here? You know tocolytics, right? Before we answer that, tocolytics, what is it going to do?
It stops contraction.
It stops contraction, right? Okay. And there is yes, and there is. So we want to analyze something. It stops contraction. That's what Maxoff and other tocolytics they do. All right. It stops contraction, and this premature separation, know that it is causing bleeding. It is causing bleeding, and if there's no contraction, will bleeding continue or stop?
Bleeding will continue.
Bleeding will continue. So if you stop contraction, bleeding will still continue. And tocolytics are going to stop contraction. Oh, it makes sense. So it means that if you are dealing with what's the name? Premature separation of the placenta, know that tocolytics are here contraindicated. All right, because it's going to prevent contraction and can even worsen maternal hemorrhage. Okay, and if it happens, fetal compromise. All right, so know what is going to happen. I please okay before you choose whether this medication can be given or not. All right, so please know that. But apart from this, you have to know the other listed. But let me ask you, can this lead to acidosis? Can premature separation? Yes, please. Someone wanted to talk, please. Can it lead to what question did I ask?
Acidosis.
Yes, acidosis.
Metabolic acidosis. Yes.
And even respiratory acidosis. How about that?
Yes.
Because acidosis all has to do with, when we talk of respiratory acidosis in the fetus, we are dealing with lack of oxygen going there, and there's building up of carbon dioxide in the fetus, leading to acidosis. So it could be a complication of this. All right. But when there's ongoing bleeding, know that we are going to give other blood products. Like what? What are you going to give?
You can give FFPs. You can give FFPs, and then you can give actual blood.
Class?
Yes. You can give FFPs. Why? If there's what? DIC. Because in DIC, the platelets, the clotting factors, the fibrinogen, they're all low. So we give fresh frozen plasma. That's FFP. Okay. If there's the PT and the APTT is high. All right. So that's what you have to do. But if you're giving FFP, please monitor for fluid overload because of potential increase in fluid. All right. We give your blood products. Okay. But before you give, know the blood type of the mother. So we are closing. Let me ask you, if the mother is O positive, what kind of blood will the mother receive?
O positive or negative?
Positive.
O positive.
O negative.
O negative.
All right. AB negative.
I'll see only from AB.
AB negative, O negative.
AB
Or
negative.
A negative.
From
O
O.
negative.
Or A negative, B negative, AB negative, and O negative.
Okay. Is someone confused?
No, I'm saying O only receive from O. So they can't receive from A or B or AB.
Okay.
Yes.
All right. So, okay. So if the mother is, let's say, A negative, the mother can receive blood from O what?
Negative and A negative.
O negative.
A
O.
negative.
How about positive? A positive.
A positive can receive blood from O positive or negative.
No, what I'm saying is that the mother is A negative. Can she receive blood from A positive?
No.
No. Because of that positive.
No. Resource factor negative can never receive from a positive resource factor blood.
Resource what?
A resource negative
Cannot receive. What
from
about
a positive?
Okay. What about if the mother is A positive? Can she receive blood from A negative?
Yes.
Can she?
Please, you said it.
Yes, please.
Yes,
You can receive.
Okay. I hope this one is not difficult. So that's perfect. All right. Except someone is confused, then I'll explain it. If not, I hope you're all okay.
So please,
All right.
can you finalize it as in you say the final way, you have your final say on it so that we confirm. Maybe someone may be holding.
Right. So let's assume that take it like positive and the negative. Okay, resource factors. Take it as a gun. Okay, like a positive means that the person is having a gun. All right. So if you are having a gun, and negative means that no gun. So assuming I'm A positive, having a gun, someone who is A negative with no gun coming into my place or coming to rob me, who fears most?
The one without it.
The one without a gun. Okay. So the one without a gun, if you are going to a house of someone with a gun, it means that you cannot cause harm because you have no weapon. Are you okay? You have no weapon. So you going to a house of someone who is positive, you cannot harm because you have no weapon with you. And someone without a gun, A negative, and someone with a gun, A positive. So A positive coming into the house of someone without a gun, A negative, mean that the one without a gun, you are at risk. Because the one with the gun coming to see you can harm you. True or false? True. So obviously the same thing with this. A negative, no protection. no gun. Okay, so A positive, when he's coming, he can harm you. But when you are A positive sitting in your house, A positive, and negative without a gun coming to see you, the person can't harm you. So always we are looking at the harm. The harm, that is the one coming. So me being positive means that I am already armed. Okay, the one coming, can the person harm or not? Let's see. Is he having a gun? No, negative. So coming to my house, he can't harm me. So always know that whenever you are positive, you can equally receive from negative, because the one is negative, no gun, he cannot harm you. I hope that is simple, right?
Yes, boss.
All right. So that's it. So irrespective of the wherever the person might be, you can easily answer it.
Thank you.
Okay. That brings us to the end of today's class. Good evening once again. Any question, any submission before you close?